improving implementation of IPC and AMS in a One Health perspective. I would like to call onto the stage Asher, who is going to do the presentation for us.
Thank you, Mel. Thank you very much. Okay, so we're ready for the next session, and on behalf of all my JAMRAI, AMS and IPC colleagues, I'd like to introduce our session on improving the implementation of AMS and IPC from a One Health perspective, and to share with you our work so far and our focus and next steps. But to begin our session, we'll show you a 2-minute video to introduce the importance of linking AMS and IPC. But first of all, a big thank you to our JAMRAI communication colleagues who have produced this video for us. So if somebody could put on the video.
AMS and IPC, why link them? Antimicrobial stewardship and infection prevention and control are essential interdependent strategies in reducing antimicrobial resistance. Their integration within a One Health framework acknowledges the interconnectedness of human, animal, and environmental health. AMR transcends sectoral boundaries, requiring a coordinated, multi-sectoral response to align policies, enhance collaboration, and ensure effective implementation of control measures. AMS promotes the prudent use of antimicrobials to prevent overuse and misuse, while IPC aims to prevent infections, reducing the need for antimicrobials and limiting the spread of resistant strains. Since both involve behavioral changes, a behavior science perspective enhances their effectiveness. Linking AMS and IPC creates a synergistic approach that slows resistance development, improves health outcomes, and minimizes the spread of resistance genes in the environment. Successful AMS-IPC collaboration depends on strong leadership, harmonized policies, and shared resources to optimize efficiency. Education and training are crucial, ensuring that professionals across human, veterinary, and environmental health understand each other's roles. Standardized approaches across sectors foster consistency and measurable AMR reduction. The impact of AMS and IPC collaboration is profound, preventing infections and ensuring prudent antimicrobial use slows resistance, reduces healthcare costs, and limits environmental contamination. A One Health approach strengthens AMS and IPC strategies, requiring collective action, standardized protocols, and cross-sector collaboration. By integrating policies and fostering long-term commitments, AMS and IPC together offer a powerful means to protect public health, animal welfare, and environmental sustainability in building a One Health world to reduce antimicrobial resistance.
So in conclusion, AMS and IPC are two essential independent strategies in reducing the antimicrobial resistance. By working together, they create a synergistic approach, and as we know, successful collaboration depends on strong leadership, harmonized policies, and shared resources. Ultimately, collaboration only works when everyone understands each other's perspectives and approaches. It also requires the willingness from authorities and sectors to work together, and this is hard work requiring ongoing cooperation, learning, and commitment. It demands a continuous effort from all stakeholders because standards and guidelines cannot do it alone. The importance of AMS and IPC collaboration is also reflected in the EU Council recommendation from June 2023. These recommendations stress the need for the cross-sector and cross-country collaboration, the prudent use of antimicrobials, and high IPC standards. Education and training are crucial to equipping professionals with knowledge of AMR, IPC, and the One Health approach. Our AMS and IPC JAMRAI activities aligns with these goals by fostering AMS-IPC collaboration involving the stakeholders, defining European standards and promoting the peer-to-peer programs and professional networks. By aligning with the EU recommendations, we contribute to a coordinated European response to AMR. Our work on AMS and IPC shares common goals across sectors to enforce implementation of core components and core competences. Together, we focus on standardization, implementation support for concrete actions and knowledge exchange to create a structured approach in Europe. A key step is the development of standardized European frameworks with stakeholders, outlining requirements, recommendations, and roadmaps. Effective AMS and IPC implementation requires tools, support systems, behavior change science, and peer-to-peer exchanges. And by utilizing these best practices and expertise with the maximum impact, institutions can enhance infection prevention and antimicrobial use and reduce the infections and AMR. So finally, collaboration, communication, and knowledge sharing are essential to advancing on our AMS and IPC objectives. Thank you. And now we are moving into our first panel discussion, which Belle will take care of.
Thank you very much. All right, I would love to thank you very much for presenting for us. And I would like to invite the panelists and also connect our online Zoom. It's always lovely when you get to meet the panelists for the first time on stage. And so I'm now going to just quickly, as I say, I'm getting to meet all of you today, and you're getting to meet me. And on top of that, we've got a couple of people online. Now we're going to manage, I've been requested to manage this particular panel in a conversational tone. So we're going to have two parts, two questions. The first question that I am going to be addressing to you, and I would like you to think about it. I'm going to ask each of you to give a short answer, and then a little bit of back and forth for the first part. Okay, so I'm going to introduce the first question. Is anybody managing to connect our, yeah, there you go, our online panelists. Okay. What I'm asking is that after the first round, if you feel you would like to respond or answer to something, that you just indicate to me, all right? So the question that I have been asked to cover with you very specifically is, how do you specifically, you as an individual, create these synergies? You are working on policies and frameworks. What is it practically? How do you create the synergies between AMS and IPC? Okay, yes?
Well, if I can start, possibly I need to introduce myself and a little bit of my background. I do work for European Commission, the same Directorate General as Velina, Julia, and Ariane. However, I'm actually Directorate F, which is based in Ireland, and we are pretty much auditors, to be perfectly honest. So we haven't maybe got that much of first-hand experience in creating these synergies. It's more about observing what's going on in the countries that we visit, and that's the member states, and that's the third countries so far. And this actually aspect is the EU candidate countries. So I can tell you that we do have very good synergies, the One Health synergies, because apart from the audits, we also been doing together with ECDC and Diamantis himself, One Health country visits, when we observe the synergies rather than create themselves. So
Lovely.
I can talk from this experience rather than my own experience.
Okay, thank you, that's perfect. Yes?
Is it on? Yes, no, sorry. Well, when I think of AMS and IPC, they are completely interdependent. So I think of it like if it was like a bottle of water, that you want to preserve the water and you put a lid on it, but there's a hole. So even if you put the lid on it, the hole still makes the water leak. So you really need both approaches if you want really to tackle antimicrobial resistance. So it's completely one dependent of the other. So how do you put together people that normally don't work together? So one of the main areas in which you have to work first to start with is to have joint training and education. So you have to put the people together, not in a Zoom meeting, physically work together so that they start speaking the same language. And that's crucial because some talk about infectious diseases, about what happens in animals or what happens in a hospital, etc. And the other are only focused on management practices, washing hands, etc. And it's very important that we see that one is completely dependent on the other and one needs the other. So it's not who is more important, it's going out of your comfort zone and speaking a common language. And this is probably one of the secrets where you start and seeing it. Also, yes, Jeroen, please.
I just wanted to add to that because I think indeed it's very important. This should be done together, and in hospitals people work together, right? I'm from clinical medicine. I'm actually an intensivist in background, but I do a lot of stewardship activities. And what I see is that you get into each other's working fields all the time. So it's important to assume those projects together. And I think one of the great examples that we see, and I'm here now on behalf of Drive-AMS, and Drive-AMS is a program in which we do capacity building on improving antibiotic use in hospitals, but we see more and more that that the teams that follow the trainings that we do, the hospital teams that they choose subjects in which IPC is very much integrated in the problem. I'll give you an example. Postoperative prophylaxis. Who here has a problem with too long prescribing of antibiotics after surgery? Well, I can see your hands going up. It's a huge problem everywhere in Europe. It's probably the most important stewardship problem that we have. And it's a combined problem because postoperative prophylaxis really fits nicely with preventing postoperative infections, and that's the field of an IPC specialist. So we're looking at improving postoperative or perioperative care. It's about stewardship, but it's also about infection prevention. And the strongest part there is that we actually have outcomes in terms of hard outcomes of postoperative wound infections to see if our strategies that are improving antibiotic use and that are improving infection prevention actually work out. So this is exactly the example that we need to work together.
Yeah. Okay. It's very nice that you bring this together now because it's operations, etc., in a hospital, but also in a veterinary hospital. So in the veterinary hospital, we have the same problem, that where there's too much prevention with antibiotics. Odontology is also a part that we normally don't touch, but it's very important. 7% of the antibiotics in Europe are prescribed by odontologists, and there also prevention is like the rule, is for everything. So there we have to bring also together this One Health concept. The same has happened that you think that you work in this field, only the hospital. It's the same for veterinary hospitals, for veterinary surgeries, not only for small animal practice, but also for large animal practice. So it's really One Health perspective that we have here, with AMS and IPC.
Okay.
Sorry.
Yes, thank you. So Gabriel, I'm an infection control specialist working in the Nantes University Hospital in the west of France, but I'm here on behalf of EUCIC, which is the European Committee for Infection Control, part of ECMID, the European Society of Microbiology and Infectious Disease. Just to speak about the surgery, I think surgery is a very good domain field to speak about synergies because we're facing across the perioperative pathway a lot of fragmentation. So from the beginning till the end, a patient is going through different people, the anesthetist, the surgeon, and all operating staff, surgical staff as well, and there is fragmentation of all cares provided to one patient. And this fragmentation is, I think, disrupting the collaboration, potential collaboration for AMS, but also for IPC. But I have another example to give you about collaboration and synergy. It's the surveillance of healthcare-associated bloodstream infection. Just to give you a practical example of what we're doing currently in my hospital. And I would also add the micro in the loop, microbiology lab. So we're speaking about IPC, AMS, but there is also the micro, which is another very important pillar of the collaboration. So what we're doing now is to start from the microbiology lab. So once you have a bloodstream infection from the micro, there is an information provided to the IPC team, but also to the AMS team. And they are both going to see the patient and the clinical staff. For one, the IPC to assess what is the portal of entry, to maybe highlight, a potential issue regarding catheters, regarding breach into care provided in one particular ward. And on the other hand, the AMS is looking at the treatment. But for the IPC, there is also the potential information about gaps in treatments that can feed the AMS part. And in the other way around, for a catheter and so on, there is also this information that can be transmitted to the IPC. So it's a very interesting, I think, topic, healthcare-associated bloodstream infection surveillance with a daily opportunity to meet with clinical staff and to speak with them for portal of entry, but also on other topics related to cares. So.
Okay. Can we maybe just give our online panelists a chance to step in here?
Yeah, sure. Can you hear me?
Yes.
Thank you. My name is Diamantis Plachouras. I work at ECDC. I'm a group lead for healthcare-associated infections. And at ECDC, I think this interaction and interdependency of both infection control and microbial resistance and microbial stewardship is reflected a lot in our work. We in the microbial resistance and healthcare-associated infections section, we cover both infection control and antimicrobial use and microbial stewardship. In surveillance, we do for healthcare-associated infections and special point prevalence surveys. We have both the prevalence of infections, but also the antimicrobial use, and there are indicators for both of them, and there are recommendations that come out of this work that cover both stewardship and infection control. So I think it's very important to have them together. And in addition to that, in guidance, we have developed earlier on microbial steward role of infection, of the interdependency of the interaction with antimicrobial stewardship was emphasized, and currently we're working on European EU guidance for infection prevention and control, and there also it's very prominent that there needs to be interaction with antimicrobial stewardship. And I mean, this is also something that is very clearly stipulated by the third strategic objective of the WHO Global Strategy on Infection Prevention and Control. And in addition to that, and bringing in the One Health perspective, as Iwona already mentioned, we are doing joint country visits that are looking in both the animal and human health, and they are addressing both infection prevention and control and antimicrobial use. So in all these aspects, I think it is shown that how important it is that there are synergies between these two. And I think this very nice video you showed in the beginning very nicely illustrates why this is important.
Thank you very much. I know you want to, I'm just wanting to check with you. Does that mean yellow for the first half or yellow for the full conversation?
Sorry, yes, I messed up. Green.
It's still green. Okay, I was just getting really nervous over here. Yes, can I have your answer?
I just wanted to shortly comment, and thank you, Diamantis. I think you're right. There's a lot of interaction between the two fields of interest. What I feel, if we look at capacity building programs to help implement stewardship programs or IPC programs, what we have in common there is indeed, and I think that's been very well described in the EU-JAMRAI project, we have behavioral science, because many of these aspects of both stewardship and IPC, they are about behavior change. It's about improving hand hygiene, but it's also about improving appropriate use. And that's where we find each other, because that methodology is very similar, and it's very much applicable to both these fields. So indeed, when we create capacity building programs, as it's done here in Work Package 8 and Work Package, 6 and 7, we have to really cover that we use these kind of methodologies to help people really change. And I think there's two aspects of it. First, of this using behavioral science. The other thing is, and I think that Diamantis would definitely approve with that, it's measure and improve, right? So you can't improve if you don't measure. So we need to measure quality of use. We also need to measure quality of hand hygiene, and then see what our strategies actually are doing for that.
Ladies next. You can come afterwards.
I wanted to bring on the One Health a particular example, and here's a shout out to Sweden, because I have said to the large Swedish contingent here that I will mention our last visit. It's a One Health visit done together with ECDC on invitation, not an audit, a visit kind of to help. In that case, it was the review of the national strategies, but I want to go a bit deeper into IPC in general. Yesterday, I attended a workshop on IPC and AMS in animal health, and there was a lot of talk about what has to be done, what will be done, and how we will do it. We need to remember that some countries are more advanced than others, and there is nothing wrong with that. Some countries started much earlier. In particular, this particular example from Sweden goes back 20 years ago when we had, around 20 years ago, when there were first cases of MRSA, MRSP in dogs and then horses. The collaboration with the human side started. There was a guidance how to handle. And then further on, we had something quite exemplary. We had IPC nurse from the human side, the human health sector, working together with the veterinarian from the competent authority, a local competent authority, visiting practices and setting up this model for IPC in the veterinary settings. That resulted actually in legislation. It's the national legislation. It's obviously not applicable everywhere. It's like kind of a first example. But this collaboration obviously shows us that there's a lot of common issues, like mentioned the hand hygiene, use of protective equipment, use of medical devices, etc. It's a very different settings. But we kind of seen this could be working already. And then 10 years on from the legislation, there was a follow-up, and we know that Sweden is quite open about it. There were different issues still found, but this collaboration started very early, and it's a way to work forward, and now obviously kind of to fine-tune it as well. So we do need to learn from each other, and there's very good examples of One Health collaboration are already there.
Yes, because what is a hospital? You know, it's a place where the concentration of bacteria and transmission is highest. It's the same as a farm. In a farm, it's a concentration of individuals where also transmission of bacteria and pathogen is highest. So in both settings, so I understand that you work in the hospital, but in both settings, you can implement IPC measures. And it's exactly the same, you know, that you have to, instead of changing your code, you change your boots or whatever. But that's how we have been able in Spain and also the Netherlands to reduce 70% of antibiotic use. It's not because we are using reducing 70% and at the same time increasing the production. So the pig production in Spain is now #1 in Europe. So while reducing 70% of antibiotics, you have been able to increase production. How is that possible even? It's because the IPC measures are being so effective, and that is because you communicate, you talk about the bacteria, external biosafety, internal biosafety, and all these rules are essential then. So you can really, in fact, reduce antibiotics by increasing IPC measures in all settings, including human settings and animal settings. And of course, both of them related to the environment that I so highlighted before that we can't forget. That's extremely important.
So our follow-up question, perhaps I'll let you, I'm just going to give you the follow-up question and then I'll let you answer. The follow-up question is really going to be very specific. What advice can you give to EU-JAMRAI? All right, so it's really going to be concrete advice. Online. You wanted to carry on.
Yeah, thank you. First of all, I will come to your question, but first of all, I would like to say that because you asked first, you know, what needs to be done in practice, and I think in practice, both the infection control and the stewardship programs, because we're talking about programs, we're talking about sets of activities with a specified aim, and they may have the aims are not totally the same, but in the area of AMR they converge, both for IPC and for stewardship. So they need to be coordinated, and they need to be they need to be having joint assessment of the situation based on shared data. And then I think, and the most important is that there needs to be a joint development of the strategies and the targets, because they both infection control and stewardship, they may be a bit more, one of these two approaches may be more suitable for some pathogens, but in the end they're both important. So to maximize efficiency, there needs to be full coordination. And I think there was also very nicely, I think we heard about the importance of capacity building, and especially the importance of changing behavior, because this is what is common in both. I mean, we don't lack the knowledge on what needs to be done. We know very well what needs to be done. What we lack is how to make things happen, how to make sure that the healthcare workers appropriately and consistently apply hand hygiene, how do we make sure that the prescribers use antibiotics only when necessary, and then they select the right antibiotic. This is what we lack. And in these two approaches that already were mentioned by Jeroen, first of all, behavioral change science, and also quality improvement approaches are what will be really effective to make sure that what needs to be done is done and is implemented. Now, and there, I think the work of, and I will coming now to your question, I think there the work of EU-JAMRAI to your work is really an excellent opportunity, because it is addressing all these areas. And it's not only in the work packages that have to do with stewardship and infection control, but it's also with the work packages that have to do with the national policies, the national action plans, that where there is the opportunity to make sure that both areas are addressed, are interconnected, and the synergies are advanced. So first of all, I think the first is to support the countries in advancing these synergies with a tailored, but there I think there is an opportunity to have a tailored approach based on the assessed needs, because these needs differ among the countries. Second, and this is something that is already, a lot of work is put in that, is to provide tools to support implementation based on behavioral change approaches. And the third one, I think, which is also very important, is to ensure that the competences of the infection control and the stewardship professionals includes competencies to develop and apply behavioral change approaches, so that in the end they are empowered to actually make things happen.
Super advice. Yes?
I would summarize it, in my point of view, in 3 points. Joint training and education, capacity building, behavioral change. I think this is extremely important. Second one, and we have not talked about, integrated governance. I think that's very important, to put the people together, make a good structure, so that the governance is really perfectly defined, who has what role, and the decisions can be taken top-down based on bottom-up discussions. And the last one, we have not also talked about enough, but we have another half an hour, is data-driven decision-making. So I think that we really have to collect all this data, and then using artificial intelligence, because we have many different places and many different data, and we have not talked enough about it, but I think that we have really to include all our behavioral change and all our data-driven decision-making with all this data, integrating with artificial intelligence, to be able even to predict, you know, and dissemination and spread of different outbreaks in human medicine and also in animal medicine.
Thank you. 30 seconds or 45.
Yes, I'll be short. My major advice to EU-JAMRAI is don't reinvent the wheel. We have a lot of activities going on in Europe. I work with ESCMID a lot. If you're looking at networking, please look at ESCMID. ESCMID is the network for clinical, I'm looking at the human side here, but that's surely going to be these kind of organizations in the other parts. Look at what's going on there already. There's a lot of programs going on, capacity building programs. Please try to use the experience that's built up in all those activities, also from our own Drive-AMS program, and build upon them. We're very open to work towards that, but don't reinvent the wheel.
Super.
Well, I was going pretty much to say the same. I think JAMRAI is already doing it. To a large extent, I saw a collection of guidance documents that have been published already by a number of member states on IPC, on AMS. Some of it is, especially IPC, is kind of international. You know, you can use it in different settings. Obviously, it will be different for small animals, for large animals. With treatment guidelines, sometimes you have to, well, most likely you will need to look at the resistance situation in the country. However, there will be also some synergies. This is a base that you already have, and then you can always talk to your colleagues to get further. And I'll do some self-promotion here. As DG Sante, we have published the reports as well. So we published a report from Sweden when you will find much more details than what I managed to say. And we also have prudent use of animals reports from a large series done a number of years ago. If you struggle to find these reports, please give me a shout.
Thank you very much. Bruno, 15 seconds.
It's Gabriel, but
Oh, Bruno.
doesn't matter. You
Oh,
can
okay.
call me Bruno, it will be the same.
I got the names wrong. There you go. A bit of humour, yeah.
You can call him
change
Gabriel.
seats.
Just yes, to keep on time. I have one comment before giving some advice. In France, 80 to 90% of antibiotics are prescribed outside the hospital, and only focusing on hospital, there is still a lot to do in hospital. But focusing on hospital is missing a large piece of the puzzle, I think.
Okay.
So getting outside is very important. It's very challenging, very important. And to finish, another comment, we're often working hospital by hospital without connection across hospital, long-term care facilities and primary care. But AMR is following the patients, and the patient is going across different hospitals, across different sectors.
Thank you very much. Thank you to all of our panelists. It's so wonderful to have you here. Your advice is well appreciated. I'm going to now invite Michael to take the stage and introduce the behavioral part of this session. I think you're on the next panel as well, aren't you? Oh, you're not on the panel? Thank you. You may leave the stage. Thank you.
Okay, good afternoon. My name is Michael Borge. I work as the lead for both IPC and stewardship in my hospital in Malta, which is Mater Dei. And I think what we've heard this morning is pretty clear, that antimicrobial resistance is getting worse, not better, in Europe. And this is quite evident from, as Velina mentioned this morning, from the latest updates from ECDC on the progress or otherwise of achieving the relatively modest AMR targets set by the Commission, and that's the CRE picture that was mentioned this morning. Practically every single country is in the red. And the reason for this, I believe, is quite obvious. The drivers of AMR, what we have already heard, namely IPC and stewardship in Europe, I would say globally, remain suboptimal. You only have to look at the latest results from the ECDC point prevalence survey of EU hospitals, where if you look at the alcohol rub use, this suggests that hand hygiene compliance is probably in the region of 25%. 15 years after the clean care is safer care, that's as much as we have got. If we look at, again, as Jeroen mentioned, antibiotic prophylaxis and surgery in the majority of EU countries, EU hospitals, 50, 60, 70% of patients undergoing surgery get prophylaxis for well excess of 24 hours, which is the evidence-based recommendation. And again, as Gabriel mentioned, if we look at the Eurobarometer survey, again, the last one, we find that more than half of antibiotics in ambulatory care in Europe are prescribed for colds, flu, sore throat, and COVID-19, all of which are primarily viral conditions. And we've heard already this morning, Doctors know that these conditions are viral, yet they prescribe antibiotics. Healthcare workers in hospitals are well aware of the importance of hand hygiene, yet we struggle. So why is this the case? Well, I think, again, the evidence shows that if, again, you look at the AMR epidemiology, and we know how diverse it is in Europe, least in the north, increasing in the south and the center, and then massively exploding in the south and the east, the main factors that explain this difference are not medical, but they are behavioral, and primarily they are socio-cultural. So clearly, again, as has already been alluded in the panel, behavior change must be our focus. And it hasn't been in the past. Indeed, as part of our work package, we surveyed a number of participants in our first workshop, about 150, and asked them how many of them had actually been given training in behavior change as part of their specialization. The reply was 7%. So it's not surprising that we are struggling. So where do we need to go? Well, the vision we have, at least in our package, is that we need to enhance the use of behavior sciences, as Diamantis alluded earlier, to support the implementation of IPC, as well as stewardship, which my colleague Josera will be talking about after me, at the different levels of healthcare systems. And in IPC, we believe that this can be done by establishing a pool of IPC practitioners who are both trained and, most importantly, competent in implementation science, because then they can generate interventions informed by evidence-based behavior science and support what, again, Jeroen mentioned earlier, effective IPC behavior change. So this is what we're doing in 7.4. We basically have 13 countries, and together with our colleagues in Finland, we are coordinating this behavior change in IPC proof of concept. So basically, each participating hospital from those 13 countries has identified a priority IPC behavior, which is different from an IPC practice, but that's something we can talk about later. And they are going to explore the barriers and the facilitators using, again, behavior science, primarily the theoretical domains framework and organizational cultural analysis. And once we have these, we will be using, again, well-established tools such as the Combi model and the behavior change wheel, which base behavioral analysis on capability, on motivation, and an opportunity, so it's not just knowledge, as again Diamantis mentioned, in order to drive a pilot in their hospitals. So we started in October. We had a training workshop in Malta, and the reason we had the training workshop was exactly because most of the participants had had very little training in the subject. So we spent the whole day going through, and it wasn't enough, but that's as much as we had, understanding human behavior, how is it relevant to IPC, what are these cultural determinants that I mentioned that are driving AMR, especially in the south and the east of Europe, and introducing the different behavior change frameworks, so that on the second day, which was in person, the first day was hybrid with 150 people, but in the second day we concentrated on the actual personnel, and then we had hands-on work, interactive work, using the Combi framework that I mentioned already to define IPC practices in behavioral terms, which is not easy, knowing how to select and specify your target behaviors, and key being identifying what needs to change. So since then, we've worked with our Finnish colleagues, and we have developed that key survey tool to identify barriers and facilitators, because that is the key of behavior change. Unless you know what your problems are, you can never address them. So we've worked, as I said again, it's the same theme, on those three key issues of capability, motivation, and opportunity, and have developed this framework tool, which is now going to be piloted and implemented by the participating hospitals. So basically, this tool will be, the survey will be run over the next couple of months, so that by the time we meet in Helsinki, we will have clear indications of where the areas we need to focus our behavior change efforts are. And in Helsinki, the idea is that we, as I said, will be identifying these behavior change intervention functions that we need to implement, characterize what policies need to be adopted, and critically, what intervention activities are needed using the behavior change wheel that I mentioned already. And we'll also have a half-day session on organizational culture, because at the end of the day, culture eats strategy for breakfast. And finally then, once that is in place, we will do the pilot, we will do the proof of concept, and for the subsequent 18 months, we will run the pilot intervention looking at these priority behaviors and critically at the end evaluate them to see if they really make a difference, and above all, what, if they didn't, was the main reason for it. Because knowing failure can sometimes be as important as knowing success. So to conclude, I believe we need, and I'm passionate about this, we need a different approach. You know, Einstein says that insanity, or said, or at least was said to have said, that insanity is defined as doing the same thing over and over again and expecting a different result. Well, we've been doing surveys, we've been doing guidelines, we've been doing policies for the best part of 25 years, and it has got us nowhere. So we need to change our approach. And that approach, again, as the panel mentioned, has to focus on behavior change. And simply knowing and simply educating and simply giving data is not enough. It does not change behavior. If it did, no single doctor would smoke anywhere in the world. So what do we need to do? We need to be driven by behavior change science. We need to have interventions that are multimodal, that are informed by social sciences, and this requires improved knowledge, skills, and competence amongst the frontline professionals and cultural awareness to adapt these behavior change tools to local circumstances. And on 9 minutes, I thank you very much.
Congratulations, it was well done. Thank you, Josera. And you're going to now do the AMS behavior. Thank you.
Everybody. It took us too long to learn or to be aware that behavior change is nuclear to antimicrobial stewardship. But it's obvious now that we look at it. If our mission is to contribute to improve antimicrobial use, we fail 30–50% of the times. And if we want to change prescriptions is the result of prescribing, and prescribing is a behavior. Indeed, it's a complex behavior. So if we want to change, if we want to improve, we have to accomplish change. So this is the reason why behavior change is so nuclear. And the problem is that it took us very long to learn this. But is this an easy nut to crack or not? Well, I like this paper. It's quite old, but it says, big truths, changing physician behavior is considered by many to be an exercise in futility and an attainable goal intended only to produce premature aging in those seeking the change, and the more optimistic might describe the process as uniquely challenging. That's what we're facing. And if this is difficult, why don't we take a technical or scientific approach for behavior change regarding antimicrobial prescribing? We need to do it. We need to have a systematic approach to behavior change. So we know how we would like antimicrobials to be prescribed, yes, we know that. But then we need to know why appropriate care is not put into practice in real life. We need to understand which are the barriers and the facilitators. And then we have to tailor interventions, because one size doesn't fit all behaviors. So we need to define specific interventions. And then we have to measure, as Jeroen said. And all what is here in this square, in this box, is behavior change. Everything inside is behavior change. And again, I said, we need to be scientific on this. And we have not been trained on behavior change. Most of our doctors, nurses, other healthcare professionals, we have not received a training. And so we need the help of experts in behavior change. And this is a different discipline. It's not us. It's strange for us. So it has another methods. Even qualitative research is something that it's strange for us. So behavior change science is based in theories. There are many, many theories that try to explain the mechanisms of behavior change. They are transformed into models to make it easier to understand the theory, and then they are framed in a way that they are more easy to use on site. So, despite we knew that this is nuclear, and that it's important to have a scientific approach with a discipline that is not so familiar to us, this has been seldomly done in AMS and also in infection control. So that's why there is a task 6.4 and a task 7.4 on behavior change strategies for both AMS and IPC. And regarding AMS, we are trying to bring the behavioral science approach to the design and implementation of AMS interventions. That's what we are trying to accomplish. And to operationalize this mission, we have devised 4 different activities, which I will describe. Our first activity was to review the literature to see how many of these theories and models and frameworks have been used in behavior change. And although many papers on AMS have hints on behavioral science, but seldomly any formal models have been, models very seldomly have been applied into these interventions. So it was difficult, no? But we decided after doing this review to choose COMBI model as our behavior change theory, model, and framework to bring to AMS. We believe that this is a comprehensive, well-integrated, and easy-to-understand framework to be brought to antimicrobial stewardship. It's general, yes, it's general. That's a virtue, but it's also a limitation. It needs to be contextualized to antimicrobial stewardship. And once we've decided this next step would be to develop a practical toolkit to help antimicrobial stewardship teams to implement behavior change in the daily activities for the design and implementation of interventions. To some extent, it's a kind of capacity building. So our aim was to create a digital toolkit, and in 2025, a digital toolkit, we thought it should have the look of an AI assistant for AMS stewards. We cannot bring a behavioral science expert to every AMS team, but we can put closer to these teams some concepts and some tools on on behavior change. So what we are trying to build is something. It's an open access online tool that is able to define and diagnose antimicrobial prescribing behaviors that help to identify barriers and facilitators, and that match these barriers and facilitators to the best interventions. And finally, that it helps teams to design interventions. And our idea is to do a retrieval augmented generation agent solution with a friendly format. And I mean, this is just even a pre-pilot. This is a concept, and with a knowledge base that it's been fed. And I've been playing with this just as a tool, being fed with the COMBI model, with some AMS principles, and it works quite well. I mean, it was just to check a feasibility, a concept. And it works, and I've tested with some people, and they like. And this is what we are now working on, is to put this into shape that can be accessible to all AMS teams. The third activity that we would like to do is to identify and prioritize the opportunities for improvement of antimicrobial prescribing. We know that this is a lot of context dependent, but we have a lot of common ground. And if we prioritize the most relevant behaviors to be improved, and if we design model interventions that can be adapted to those different contexts, we will be saving time to many people. And we think that this is something important, as we don't have to reinvent the wheel, and we don't have to make people to work on the same things all the time in different places, if this can be worked centrally. And finally, the last activity that we plan is to design an online scalable education and training program on behavioral sciences principles applied to AMS, which we intend to pilot before the EU-JAMRAI 2 ends, and it will integrate, of course, the toolkit that we are building. And thank you for your attention.
Very much. Thank you. Right. What we're going to do at this point is we've opened up to Menti. We have a couple of questions, I believe. Can we hear the questions?
Hello? Yeah. So we have a question. If behavior change is an essential component of IPC and AMS, is a one-day training enough, or how else can we achieve this?
One-day training is not enough. It's not enough, for sure. We need to work to incorporate, it depends, we have to do several things. We need to integrate behavioral changes principles in the curriculum of the medical doctors and nurses, and that we have to do that, for sure. And we have to put it into the beginning of the education. And that's one thing. And for example, we have the example of AMS, Drive-AMS, which has, as Jeroen said, longer than one-day course with programs and exercise that can be tutored, and there are several ways to do it, but one day is not enough.
And we also have still one more question from Els Bruins, Utrecht University. Can we change behavior without data on antimicrobial prescriptions, guidelines, infection prevalence?
Yes, we can change behavior, but we won't know very well if we are doing or not. So data, knowing the data is very important, having information, measuring, that's critical. And that's a critical problem that it's being tackled by other work packages here, as has been said, but it's one of the most difficult things. Even we don't have a common language. We don't have a common language to measure what we want to do, and we want to measure, and that's a big problem.
I think the key sentence I always make is, education does not change behavior, but behavior does not change without education. So, same thing, stewardship and IPC will not be changed simply by knowing the epidemiology, but knowing the epidemiology makes people understand why they need to change, and that is the first thing. The other thing I would just add very quickly to the previous question, we've always looked at IPC teams as being medical, nursing, allied health, epidemiologists, etc. I think, and I've been saying this now for the past decade, we need to also start to have behavioral scientists as part and parcel of IPC teams in hospitals.
Do we still have time for one more?
Watch out, we've got the photographs at this point. How many questions are there still?
Just one.
Can we do one last question? Okay, one last question, and then please don't leave. We're going to have photographs on the stage. I'll tell you now. Okay.
So the question is from Velina. How do you see the role and usefulness of guidelines at EU level for AMS and IPC?
It's for you, or?
It's from her.
Oh, it's from her.
Okay, now that's a very naughty question, Velina. I mean, let's be honest. I don't think, and I've been privileged to actually be invited to the guideline group by IPC, in IPC by ECDC. I'm pretty sure we're not going to change or to reinvent the wheel. There are guidelines coming out of our ears from CDC, from ESCMID, from WHO. So, I mean, IPC is IPC. And implementing IPC is the same, but the backgrounds to IPC are different. And the barriers to IPC are different. So I couldn't do yesterday's meeting because I was on the plane coming here. But if there's one thing I will contribute, it's to say, this is the key. You know, we need to understand how we can adapt to adopt. Because Sweden was mentioned. I was also in the Swedish country visit. I came back, and I was saying this in the break, and I said, I've just not been to a different country. I haven't been to a different planet. I've been to a different solar system. Because the culture in Sweden is completely different from the culture in my neck of the woods. And that's the key. We need to know how we adapt what has been successful. And my final point is, AMR is a symptom, not a syndrome. It's a symptom of system dysfunction. Okay? So it cannot treat system dysfunction by all the systems that have worked where the systems are functioning. You need to adapt it.
5 seconds.
Guidance is to AMS what education is to antimicrobial prescribing. It's not enough. It's not enough. We need larger and more powerful levers. We need other tools. I mean, guidance is necessary, but we need more things. We need co-funding, whatever. We need other tools that help to implement what the guidance, the EU guidance says.
Thank you very much. Implementation, the improving implementation of AMS and IPC in One Health. And we're going to start off with the human health. I introduce Paula and Pepe to the stage. I got it right, did I? Paula and Pepe. Thank you.
Speaker now? Okay, it's working on. Thank you. Good evening, everybody. Kaixo, in Basque language. Today, we are going to discuss how to strengthen IPC and AMS collaboration across Europe, in contrast or similarly with an analogy from the Val mentioned early this morning as the football match that is going to be celebrating on Thursday. Between two competitive teams from Spain and Italy. We are two representatives from Spanish and Italian sectors from AMS and IPC, and we are going to present a vision of collaboration in contrast, not of a competition. My name is Pepe, José Luis, I'm scientific officer, and my colleague Fortunato Paolo, research director and medical doctor from the Instituto Superior de Sanidad. And we will go through our key initiatives and results. Oh, I'm sorry, it's working on. Yes, the first point. You can scan this QR code to do any question that you would like to ask to our at the end of the presentation. Our goal is to reinforce infection prevention and control, exactly, and antimicrobial stewardship as complementary strategies. Both domains have shared common objectives, such as reducing infection and preserving antimicrobial effectiveness, with the overall objective to make Europe a best practice region to support development and implementation on AMS and IPC, not only in human sector, in all the other sectors, like as a One Health approach for animal, environmental, and plant fields. In this map is highlight the European countries actively engaged in AMS and IPC initiatives. Some countries are exclusively or solely on IMS activities, others in IPC activities, but most of them that are highlighted in the light pink color or light orange integrate both approaches. Considering in overall 29 out of 30 EU members plus the non-European members participating in both activity, engaging 57 different institutions involving a large amount of partner expert efforts and closely working between key institutions, including national public health bodies, healthcare authorities, and professional societies. This is an important idea to take in mind that AMS and IPC strategies align with national policies and try to transmit that to the real ground needs at healthcare practitioner fields. This large participation is useful because also to keep in mind that not all the countries have the same starting point situation, and our work is not only possible, thanks to contributions, the support, the collaboration, and close work of diverse stakeholders that are represented in this slide. Policy makers, healthcare professionals, researchers, patient organizations. Their expertise is essential to designing effectiveness, intervention, and success our goals that we are going to show in the next slides. The overall goal is to reduce infections and antimicrobial resistance, to reduce the number, the burden, and the impact of the infection, preserving the effectiveness of antimicrobials, while ensuring the sustainability of healthcare intervention. To achieve this, we promote evidence-based strategy coming from the insight from the previous EU-JAMRAI results, and here focus on the new activities on capacity building, peer-to-peer learning and knowledge sharing to implement a networking and competency framework. These elements will help to standardize, harmonize, and adapt each idiosyncrasy in a flexible AMS and IPC best practices across Europe, as well as also including innovations and best practices. Here we represented our main goals that are strengthen AMS and IPC strategy. We focus on multiple key areas, reviewing existing training frameworks for IPC professionals, aligning with ECDC core competencies, facilitating mentorship and knowledge exchange. Our approach also includes some collecting and disseminating pilot project experiences and monitoring IPC implementation across different levels in the countries to help the local decision makers. Also aligned, to keep in mind, with the Council recommendation with the objective published in 2023. We are also focused on different levels of the community, on the hospital and long-term care facilities, as mentioned, for example, in the previous panel discussion from the EUCIC colleague, Gabriel, this morning. One of our objectives is to map the core elements and competencies included in the National Action Plans on AMR and related strategies, establishing networking on AMS contact point across Europe to facilitate continuous follow-ups and exchange experience, and developing self-assessment toolkit for antimicrobial stewardship programs. And how to do that? Well, in January of this 2025 in Athens, we celebrated a workshop, and the discussion provides valuable insight for improving AMS governance and institutional supports, implementations, human and technical resource, evaluation interventions such as education and training and coordination strategy between the different healthcare levels that will be useful and used to identify the commonalities, commons and different elements for hospital ASP as an initial step for developing a common framework for hospital ASP in European countries, as well in the future 2 workshops that we are going to celebrate in Madrid and in Ljubljana in this 2025. Our goals also include the development of innovative tools to strengthen AMS. This includes preliminary versions, ongoing or completed surveys to identify core elements and core competencies outlined in the current national action plans on antimicrobial resistance, referring of each healthcare setting across Europe, as I mentioned previously, and the functional design of the peer-to-peer antimicrobial stewardship digital platform, which aims to host and implement these peer-to-peer programs for the promotion of good practices in AMS with experiences as mentors, reference centers, and experts in Europe. And I think that is the last slide. And
thank you. Now we will see the progresses regarding the IPC, IPC. In particular, we can say that regarding the reinforcement, the strength, the UN resources in terms of core elements and competencies, we have a preliminary version of a self-assessment tool to evaluate IPC core competencies. And also another important step is a survey to identify which are the partner needs. This is important to, as I said, to help to build human capacity on this. And here there is the space for collaboration with EUCIC. Regarding instead the support for pilot project or innovative actions, we launched the survey to collect ordinary and innovative tools for IPC. This is a sort of collection of good practices in terms of new way to implement IPC. Finally, we are designing the idea of the self-evaluation system to understand what is the status of IPC core components implementation, not only at the national level, but try to give a tool for decision makers and policy makers analyzing data specifically at regional or local level. Finally, we are doing the systematic review for optimal blood culture practice. Oh, sorry. Yeah, it's my mistake. Yes. Yes. Regarding the platform, we are now defining the platform for disseminating the existing tool and the platform that should monitor the implementation of IPC core components. But as it was said by Pepe, we need to underline the importance of one platform for mentoring online, giving resources to the participant, to the project. In Barcelona, the workshop that we did in December, we spoke a lot of topics, but mainly how to, we made a lot of networking to understand how to go from theory to practical actions in each of the tasks and objectives that I described. I would like to mention also an important topic that you will see at the end, the bottom on the right, that is also that we decided to have interview one by one to the partners to understand the needs and how we can support them to, during the project. What is for both IPC and AMS in the next months? First, for AMS us, there are 3 meetings. They are different among them because one is for hospitals meeting, antimicrobial stewardship programs in hospital, another one instead for the community, another one for long-term care facilities. This is important because we need to tune the programs for specific target. And also, we plan to design the platform and the peer-to-peer programs. For IPC, yes, we have to finalize our platform and our initiative. And I think that at the end of 2025, we will collect a lot of results. In conclusion, we need to decrease the number of infection. We need to increase the prevention. And the best, as we listened this morning, is to align IPC and AMS for the patient safety and the healthcare sustainability. We are focusing our efforts a lot on capacity building and training. Yes, as Michael Borg said today, is not enough. We have to change the way how these things are implemented. However, this is another important piece because training, at least, must be provided. We need also digital transformation. We need more tool to have data faster than before, and a new opportunity to monitor what is happening and how much we are prepared in our implementation. Next step is, yes, from theory to something of practical and result. Thank you.
Are there any questions from the no? Well, it looks like you did such a good job that nobody wants to ask any questions. Are there any questions directly from the audience? We have one question over here.
Can I just speak up?
Here we go. Thanks. There we go. Never mind.
I'm just curious whether you were discussing competencies. What exactly are you going to do with devising the competencies? Because there's already been a lot of work done on competencies for prescribers, but also for AMS stewards. Is that also going to be part of this exercise?
About you said, I'm sorry, because I was managing the microphone, about the elements, the core elements you mentioned. If you can repeat the question, because...
You mentioned that you were going to develop competencies for prescribers. And I think there's already a lot of work done on competencies written up. So I was wondering, are you expanding those to other types of prescribers, or how are you going to do that?
No. What we have in mind is obviously collecting all the information that has done in the previous EU-JAMRAI, because a lot of information regarding surveys and information from the partners and the other action plans and healthcare authorities and governmental bodies involved in the previous project, and also collecting new data, because many years or a few years are moving exactly. And now we have information from the national action plans or recommendation that are inside on the national documents, and we would like to bring in that link or gap through the ground level practitioners and their daily activities in each setting, with the one of the insights from the workshop that we are celebrating. Because there are differences between the mandatory or the recommendation or anything that is in that document, to adapt them to each level, to each activity that should be done on the ground level. Also, it's important to keep in mind one point that I mentioned at the beginning of the intervention. That is not something that should be flexible to each situation, but because one point that you remarked many times during the intervention early this morning is about capacity building. And that's something very important to keep in mind, to develop a framework, how to adapt to each necessity, each situation that is in each country, on each region, and also for each one of them. So we have a large amount of experts from a policymaker and from the practitioners, from different expertise, to develop one of that document, and also collaborating with the stakeholders that are involved in AMS and also in IPC. So that's the way to do that.
Thank you. Is there time for one more question from the room? Yeah, okay. Anybody else in the room that would like to have a conversation on the topic, or do we move on? Are we going to gain some time here? It looks to me like we've got a well-informed audience and a rather tired audience. So we're going to give them a little bit of a break, and thank you very much for your presentations. Okay, well done, and thank you. All right, I'm going to call up the next team. Coming up. We started with human, now we're going to animals, animal health in IPC and AMS.
Thank you, Val. Well, this is Anna from Animal Healthcare in Flanders, in Belgium. She's working on infection prevention and control in animals. And I'm Isaura from Utrecht University in the Netherlands. And together with AMS, we're leading antimicrobial stewardship in animal health. Oh. Please feel free to scan this for questions for after our session. This was yesterday, and it was already mentioned during some discussion panels. We gathered with more than 80 people from approximately more than 30 institutions to discuss all the problems and solutions we came up from AMS and IPC programs. And on the right of the screen, you already see some format we used, because there were like this lectures from speakers, but the focus was mainly on active sessions. And we used a lot of post-its, a lot of stickers, and a lot of discussions to collect as many information as possible and to brainstorm together. But of course, we did not develop this workshop in one day. We started working together since the beginning of EU-JAMRAI. Well, just to start with the first joint action we did, that was the development of a questionnaire. The second was to discuss the methodology for the literature review. And officially we started with monthly meetings, but soon we discovered that was not enough. So we started with drinking more coffee, but then weekly, so every Thursday at 10, we meet each other online. And we did that all, of course, also to prepare the workshop of yesterday. And because that was not enough, the best ideas come to life when you meet each other like today. So that's why we also met each other in Brussels. And this was not the end, of course. We are going to present today the results of this last year, but Anna will present what we are going to do in the following years at the end of this presentation. And to give you also a glimpse of how the other colleagues, some of the colleagues look like, because we are, of course, with all our partners and a big team. Here you see also Maria and Julie. Yes.
And it's through these different communication channels that we address 4 collaborative cornerstones. So together, we'd like to further build a repository of guidelines and tools for AMS and IPC implementation in the animal health sector. We also like to further define core elements to really work out a framework and a set of standards for AMS and IPC, thereby also identification of enablers and barriers, and lastly, further develop an expert network in the field. So to focus on our first joint action, we developed a survey last year to gather more information on existing guidelines and tools circulating across numerous countries in Europe and worldwide that assist in the implementation of AMS and IPC in the sector. This was distributed via all our partners, and as you can see, it results in a wide range of tools available, with the majority being written guidelines and, on the other hand, digital applications. Think of software platforms such as, for example, a farm management software tool assisting a farmer in implementing IPC measures. The survey results also paint a picture of a very heterogeneous audience involved, so each adapting its approach to fit their specific needs. One can imagine that a farmer, a veterinarian, a breeder, they all have a different goal, depending on whether they're working with companion animals, food-producing animals, and what their aim is in the sector. The diversity of the tools as well, ranging from educational programs to strict biosecurity protocols, underpin the complexity of the task at hand. It's not just about using antibiotics wisely, but it's about integrating a broad spectrum of practices across different contexts. Key areas of focus within these tools included education and communication, prudent use of antibiotics, and hygiene and biosecurity. But also many tools were collected that support surveillance and reporting, essential to adapt to fast-changing challenges at these times. For policymakers, the survey can offer crucial insights to further shape regulations, whereas for academics, it could provide opportunities to further steer their research. We heard it already this morning. There is a lot of knowledge. There are a lot of guidelines. There are a lot of tools. The challenge lies in how to truly implement these effectively across a very diverse sector. One goal within our task in this project is to join or to create the EU-wide platform. And it's a platform, the word we heard in the other talk as well. A central hub for knowledge exchange and for sharing resources, for sharing best practices. And by doing so, professionals across Europe could work together to more efficiently implement AMS and IPC measures. But a digital platform alone is not enough. To ensure a meaningful impact, we need coordinated efforts, as we are doing today and need to continue to do, at the national levels, through European partnerships, but also through the support and input from professional associations in the field and industry representatives. Think also about the importance of public-private partnerships that can support building a framework that is accessible, adaptable, and impactful.
Our second cornerstone was to define core elements. So why did we do that? Well, it was basically one of the results of EU-JAMRAI 1, that despite all the guidelines and standards that there are, the member states, despite that, they were not uniform. So there was a gap that needed to be addressed. Those core elements are crucial for the effective implementation of AMS and IPC programs. And therefore, we started with a literature review done by the Federations of Veterinarians of Europe for AMS. And I can show you only a part of the results from their literature review, our literature review. So we started with a lot of publications, approximately 350 as a result. And there were 3 main core elements that came up. The first one is about education and communication. All the publications about raising awareness, but also sharing knowledge with each other. The second core element that came up the most was prudent use of antibiotics, which also includes guidelines regarding antimicrobial resistance and stewardship. And the last one, reporting, monitoring, and surveillance. And of course, yesterday in the workshop, more and more core elements came up, but they need to be analyzed, and we can see if they can be added or we need more core elements. And we would like to also show you the difference we analyzed between companion animals and food-producing animals. It's good to know that for the people from human and maybe environmental, that farm animals, we cannot compare them to companion animals, as they are housed in farms and treated, if necessary, at the farm, while companion animals you can compare more with human medicine, as they are treated in veterinary clinics. And with that in mind, you can see that the results from this literature review are as expected. You see that all the literature we found about housing is from food-producing animals. On the other way around, you see that for diagnostic tools, vaccinations, you see there are more publications from companion animals. But overall, we found more publications from food-producing animals compared to companion animals. And we also want to show you some of our results also from yesterday, because we already identified some barriers, but it was a lot. As I show you in one of the first slides, a lot of post-its, a lot of IDs. So we just want to show you some of them. One of them that really came up was the attitude of the veterinarian. A lot of time was saying, well, I'm just doing this already for years. How can we change it? So beliefs about consequences of the veterinarian. Another example was the lack of knowledge, not only from veterinarians, but farmers and all stakeholders, animal owners, feed advisors, etc. Working in silos, something we already discussed, that groups of people are working in their own island, in their own organization, and not outside, not thinking further abroad. And economic constraints, which also came up from someone from the audience in a question, financial funds. Some ideas for solutions that came up, feedback, self-reflection, to handle, to deal with the attitude of actors. Education and training for the lack of knowledge, which is the easiest example. But also we talked about access to diagnostic tools. And we think one of the solutions we talked about, and we liked, and that's why we want to mention it, it was the low-hanging fruit. Just to start small, with small steps, and make that successful, and bring that along.
And to wrap up, I'd like to briefly highlight one of the last cornerstones, the development of that expert network. And I just mentioned a couple of stakeholders and networks here that play a vital role in the fight against antimicrobial resistance. There's many more across Europe and globally. And they each address a different facet of antimicrobial resistance. But for these networks to be truly effective and sustainable, they must be anchored in shared values. Imagine these networks as being trees in a forest, each tree representing a network and a stakeholder. Beneath the forest lies the mycorrhizal network. Do you know it? It's a fungal highway, allowing a seamless flow of information and data resources and energy resources to be exchanged between the different trees. So likewise, the foundation for sustainable networks on AMS and IPC lies in these shared values, in these anchors. It lies in that collaborative governance, in multidisciplinary expertise, and in effective communication. And it's through these values and building the networks, such as we heard this morning as well with surveillance data, that we can further improve data sharing, resource sharing, and engage with one another. Something that was mentioned this morning as well, and that we highlighted here, is the need for the integration of new technologies, as this is required to adapt to challenges in real time. But rather than building an entirely new network, the goal actually here is to develop an expert network that taps into the roots of the existing ones, the ones that are already in place, and connect and strengthening where we can, so we can further work towards a sustainable implementation of AMS and IPC in the sector. So as we look ahead, this is our roadmap, our joint roadmap, because we want to keep drinking coffee every week. All partners involved in the project, they will produce joint reports and publications, but we're looking for other ways to disseminate the information through the sector. Some of us will be working on farm level, roll out focus groups with some of these audiences that I mentioned in the beginning that are not represented here, but are essential for the implementation of IPC and AMS. We work jointly also on developing peer-to-peer programs and training programs for professionals in the field. And it's by working across the borders and across the disciplines that we reach the ultimate goal to create that core framework with standards that are lacking for AMS and IPC in animal health, and help further integrate these into the national action plans in Europe. As we take this forward, and we heard multiple times this morning, undoubtedly this afternoon, the fight against AMR extends far beyond animal health, and we envision a closer collaboration with our partners in the human health sector as well as in the environmental health sector. And I hope you see already that we have shared goals here, the platform, the collection of tools, the self-assessment system, peer-to-peer training programs. And after all, AMS and IPC are built on changing behaviors across the three sectors. To make this truly transformative, we also want to reach out to the teams working on sustainability, member state engagement, and awareness. It's only by aligning all these shared enablers across the sectors that can we turn the results into more impact. So together we are not just addressing AMR, we are really shaping a sustainable, unified future for human, animal, and environmental health, thereby also fulfilling the ambitious goals of the EU-JAMRAI 2 project. So thank you, Eskeri Casco, as they say here, thank you for your attention, and we're looking forward to further engage with you throughout the day. And to support that engagement, we have a QR code here, another one, to submit your questions if you have any, and please hold this code open, because we have a question for you as well. Thank you.
Really, really good job. And it also seems like the audience is suffering from a little bit of an energy lag after lunch. Once again, we don't have any questions on Mentimeter. Is there anybody who wants to quickly type in a question? Or is there somebody who might want to ask a question in the room? Just to generate a quick conversation. If not, we're going to move on and we're going to enjoy the next presentation. So anybody who would like to make a comment? Yes, we have a comment, we have a question. Yes. Okay.
It's there. The question is on the screen.
No. Okay, all right. So here, they're going to ask you a question instead.
Can they still access the QR code? Yes. Okay. I'll leave it. Yeah. So when you scan the QR code now, there should be a question. What is considered your top 3 priorities? Okay. Okay, we see already a couple of answers popping up here. There's no wrong answer here. So
I already like the first one about evidence-based guidelines.
I see another one, communication. Yeah, but did you see how many people are involved in, for example, implementing IPC in the animal health sector? The responsibility doesn't necessarily lie with the one who is trained and has the IPC certificate. Yeah? So we need very different strategies in there. Okay. Well, thank you for your input. We're going to work with that.
Yes. Yeah, they're still coming in.
Okay.
Well, we do see a lot of guidelines, and especially because we talk about in animal health. That's interesting. But maybe it just for fun, can you raise your hand if you, in your country, that evidence-based guidelines for animals are missing? And then I mean a clinical practice guidelines for specific diseases. So, yeah. I see sort of 10, maybe 12 persons. Thank you. Nice.
Any other comments from the audience while you are looking at the answers you're all putting in? I see a lot of discussions ongoing. That's good. All right.
Okay. Then we can.
All right. Okay, with this, thank you very much. And I'd like to call on the stage the colleagues from Environmental Health, Rosemary and Annie.
Hello, we are Anne Leburo from the Spanish Agency of Medicine and Medical Devices, and me, Rosemary Luijken, from the Dutch National Institute for Public Health and the Environment. And we are going to present about AMS and IPC in the context of the environment and our joint approach. And to sort of stress this joint approach, we will be behind this desk with the two of us. Before we start with our presentation, we have a question for you. So please open Menti again. And as we would like to ask you, what comes to mind when you hear antimicrobial stewardship and infection prevention and control in the context of the environment? As these concepts are not or much less established in the context of the environment. So we are wondering what comes to mind for this audience and the people at home. And I can also suggest if nothing comes to mind, please write nothing, the word nothing. So we see
unknown there somewhere.
Yeah. We have water, surveillance, wastewater, spill out, treatment, planetary health, already biodegradable, and then it's moved, climate change, waste management is getting bigger and bigger. Thank you. Well, I think the audience is still awake. Yes. Thank you all for your input. And I think many of these concepts we will address in our presentation. So nice to know that there's already a lot of knowledge out there.
Yeah, we can go on if you want.
Can I go on to the... Yes, because this code is for open questions. During the presentation, you can type in an open question, just as the other presentations.
Good. So as we have seen in the cloud of responses, many ideas come up when we think about applying these strategies to environmental context. And this is partly because AMR in the environment is such a broad topic, but also because there may still be some uncertainty about how exactly the environment fits into this AMR issue. And the truth is that the environment can play a major role in both the spread and development of antimicrobial resistance. Let's see how. So if you take a look at this diagram, you will see that first, resistant bacteria, resistance genes, and antimicrobial residues, known as AMR determinants, are released into nature through different anthropogenic activities that serve as emission sources, such as effluents from healthcare settings or manure from animals, for example. Once in environmental matrices like water, soil, and air, these determinants are spread or can even mix, evolve, and contribute to the emergence of new resistance. And eventually, over time, AMR determinants can find their way back to humans and animals through different exposure routes, increasing the risk of transmission within these populations.
Yes, so because these concepts are not so established or well known, we defined it for this project. And IPC, in the context of environment, we defined as activities that reduce the emission of AMR determinants resulting from human practices to the environment. And here you can see several important examples of activities and domains that we will be working on.
Good. When it comes to antimicrobial stewardship, traditionally, AMS has focused on the rational use of antimicrobials in humans and animals. However, our joint action spans this concept, understanding AMS as the responsible management of antimicrobials in a much broader sense to consider the impact of prescriptions in the environment. So, as a result, EU-JAMRAI promotes a cross-sectoral approach moving beyond a purely clinical one, where prescribers, pharmacists, but also non-prescribing professionals all have a role to play in tackling AMR by bringing their specific expertise into action. Therefore, incorporating the environmental dimension into AMS strategies reinforces the One Health approach by offering the complete picture of the problem. And of course, this can help improve outcomes in both human and animal health, which eventually strengthens our health systems. And before moving on, I just want to emphasize that beyond the EU-JAMRAI, there is a growing tendency of other entities to contribute to the conceptual evolution of AMS, what has been supported, for instance, by the EUCIC, from the political declaration by the EUCIC. Yeah. That's yours. That's mine. Yeah, sorry, that's mine. So now that we all have a more solid understanding of AMS and IPC in the environment, it's easy to see that we share a common goal, which is to reduce the emissions of AMR determinants into the environment. If we go back to the diagram explained earlier, we can observe that environmental approaches in AMS and IPC follow an origin-based strategy. This means the aim is to tackle the problem right at the source, targeting the point where AMR determinants can be potentially released. And this is exactly what makes these environmental strategies so valuable and cost-effective, as they can help prevent the spread of resistance before it becomes a bigger issue in public health or animal health. Yeah, now this is yours.
Yes. So already introduced by Anne, we want to reduce emissions to protect, indeed, public and animal health by the reduction of exposure to AMR in the environment, for example, through bathing waters or through irrigation of crops, and by the reduction of selective pressure of antimicrobial residues and the effect on resistance developments in the environment. So, how are we tackling these goals in JAMRAI? Well, through several activities. and in line with Council recommendation on using practices that reduce environmental exposure and on education and training of professionals. Our first activity, our big goal is to determine best practices for environmental IPC interventions that reduce emissions of AMR to the environment.
Yes, and then we will train professionals on the identified best practices to empower their environmental stewardship. And in the image you can see people training. This is obviously a different kind of training from what we aim to implement. We will not involve any physical effort, by the way. In any case, it serves as a useful illustration and metaphor because we really want to capacity build that muscle, let's say, referring to strengthening the core elements that make up the environmental strategies for AMS and IPC, such as strategic planning, policy implementation, wastewater treatment and reuse, for example, among many others. Good, so here's how we plan to achieve this. First, we are putting together a training and assessment plan, which includes our target audiences, learning objectives, and the best educational approaches to use. Simultaneously, we are mapping out IPC interventions and will compile a document highlighting best practices on IPC actions in the environment. Next, this document will serve as a key resource for developing training contents in alignment with our previously defined learning objectives. And finally, we'll pilot test a training intervention to disseminate these best practices effectively. Well, about who will we train? What are our target audiences? We did an internal survey and examined cooperation frameworks and recommendations from the quadripartite and European agencies to create a comprehensive framework which included all cross-sectoral stakeholders involved in antimicrobial stewardship. But given the time and resource constraints of our work, we needed to refine this initial list. So we examined the role and competencies of each stakeholder in the list in relation to the environmental approach, of course. And what it identified were the main gaps and concerns affecting AMR in the environment today. So on the slide, you can see the top 5 concerns that we identified. And as a result, we concluded that we will focus our efforts on high priority target audiences, such as policymakers, antimicrobial producers, health managers, food producers, and wastewater managers. But we'll also try to indirectly target secondary audiences like prescribers, dispensers, researchers and students, or the general public through the collaboration with other teams and colleagues in EU-JAMRAI that are more focused on these target audiences. So finally, we also created a network of representatives of these target groups with more than 80 people involved so far, because it was very important to us that everything from the needs assessment to the delivery of the trainings was a participatory process with the implication of our target audiences.
Yes, so what else we are doing is to determine these best practices. We first have to map all interventions that are currently out there in the countries, deliberately or not deliberately, aiming for reduction of AMR determinants to the environment. And that's why we are currently drafting a survey with our group that will be sent out to the countries involved. And 2 interesting things I want to stress, and challenging things and interesting things, is the diverse group of stakeholders, and also a bit different maybe than classical group of stakeholders, just like Ani already mentioned, but also this morning mentioned by Caroline Whalley. We are talking maybe a different group than the human and veterinarians are spoken about this afternoon. And something else that I want to highlight is that because there's not one common approach, not one protocol, we are collecting information from maybe general practices, pilots, research, and, if present, full-scale national programs.
Okay. Thanks. At the same time, our team reviewed existing training materials on the topic to see what has already been done and what is still missing to be done. So we compiled over 600 scientific publications, 69 learning materials, 88 trainings, and 135 regulatory guidelines. And what we found was that most current AMS frameworks mainly focus on prescribing good practices. But there is a gap when it comes to providing guidance for implementing antimicrobial stewardship in environmental contexts. Also, AMS in the environmental framework is mostly about basic awareness, with limited legislation and a lack of detailed resources on best practices. Additionally, key stakeholders outside of prescribers are often overlooked, and face-to-face training opportunities are minimal, which restricts the transmission of practical knowledge. So the conclusion is that current opportunities to learn about AMS from an environmental perspective are critically limited. There is still a lot to do. We can't expect this edition of the joint action to fill all these gaps at once, but we must take on this challenge and start somewhere. So we followed the Council recommendation on AMR, the 22nd point about awareness, education, and training, which specifically calls for ensuring cooperation with professionals in education and pedagogy to train on IPC, environmental risks, and AMS. And according to this statement, 6 months ago, in collaboration with the communications team, we subcontracted a group of educational experts to explore the best methods for training professionals on AMR. Since then, we've been working closely together to develop a toolkit, which will be a step-by-step guide for implementing innovative training interventions in this area. And our goal is to better understand what each professional needs in terms of learning, so that we can tailor our approach and make a real lasting impact with our interventions. And of course, we also believe that this material will be valuable to any other team, project, or expert who wants to develop their own training on AMR within or beyond the EU-JAMRAI.
There was an animation in here, but well, now you get all the text at once. So, but I will talk you through it. So now to the practice. To make our aims and our work even more clear, we like to give an example of a project about responsible management, so AMS, and IPC in the environment, a project of which we will collect information through the survey and will help us draft best practices and training materials for professionals. In the Netherlands, there's a project with a chain approach, meaning including actors from industry to healthcare to wastewater treatment plants. And the aim of this project is to reduce residues of pharmaceuticals and micropollutants in treated wastewater, and ultimately in surface water, as too high concentrations of pharmaceuticals in surface water was the initial reason for the project. And for us, the IPC intervention of interest is advanced wastewater treatment. And this project is piloted on a scale of research, several research projects, and several demo treatment plant locations are implementing advanced wastewater treatment. There's a big group of stakeholders, several mentioned here, or not. Something with the slides. And of course, what is very important and what we also will research during the project is to assess the efficiency of the intervention. And in this case, this project assessed this through a removal efficiency of selected indicator substances, including some antimicrobials. And just as a side project, but luckily they had the side project, they also looked at antimicrobial resistance genes. And the results still need to be published.
Yeah. So going back to our calendar, from now until the end of the year, our key collaborative activities will include a focus group next week in Granada to validate the educational toolkit, then a survey to map environmental IPC interventions across the EU, and a second workshop on environmental stewardship in Athens in September. So please save this date stay updated, and if you want to collaborate or participate in any of these activities, don't hesitate to contact us after the meeting. And we have a couple of questions now.
Let's go back to Menti again, because now we had this presentation, and we hopefully give you a nice overview of the work we are doing. So we have two questions, and the first one is multiple choice or a single choice. Do you see any connection between our work in AMS and IPC and your work? And it should be a yes, no, I don't know question. And I hope we can see the answer.
Yes.
Oh, wow.
That's good, actually.
Yes. How many answers? 70 answers. Well, that's great that many of you see this connection. Of course, now comes question 2. If so, could you specify which connections or synergies between our work and your work you consider most relevant? And this is an open text field, and hopefully the different answers will also show. See some similar answers. All these responses will also help us in the next 3 years, making the right connections with all the different domains, because as was said this morning, the environment is not an endpoint, is not a silo on itself. We really need the human and animal health connection. There's a lot of wastewater coming from all over the hospital, animal settings. Where is the connection? It's, I guess, somebody who chose an I don't know. Still thinking about it. Manure control. Yeah, this is great. I think we will summarize it after the meeting.
Yeah, I think we need to take a look at all the responses, because they are so different and are covering so many different topics. Aquatic animals, yeah.
Yeah, so thank you. Are there other questions? We can repeat them if you just say them out loud.
There is one question from Paula from the WHO Europe. How are you planning to raise awareness of IPC carbon footprint?
Yeah, so the question is, how are we going to raise awareness about the carbon footprint of IPC? Yes.
Do you want to go for that? Because IPC is yours, but well, I can try to respond as well. I think for now, at least, we are not covering this in our activities. This is not part of our scope. We didn't include these concerns about the carbon footprint, and we will not be covering this for at least the next months. So this is not something that we are really working on, right?
No, we're not working on it, but I think we are aware of it, that of course in these interventions you have several things to consider, and one is the efficiency of removing pharmaceuticals and AMR, but also one is the carbon footprint of this all. So I think that's
indirectly going to be covered, but
yes,
indirectly. Yeah.
Yes, one of the questions mentions, for example, from Els Bruins from Utrecht University, how should you consider the biodegradability in the environment of when we categorize antimicrobials? So
can you?
Yes.
So when antimicrobials,
it is on the biodegradability of antimicrobials, and I guess you are referring to the treatment choice.
Sure. Yeah.
And considering this aspect. So I'm not an expert on this, but I know that there have been some discussions on the topic, and actually we are coming from the Spanish Medicines Agency, and in this case, Ricardo Carapeto is working on these topics, so maybe he can answer this question afterwards and give a more complete answer by email. But yes, I know that there are some discussions. As long as I know, there is still no guidelines on this topic, at least at the national level, but we are working on that. And maybe not on antimicrobials, but I know that it's being really considered for other contaminants and pollutants. Yeah.
And one last question online from Cohen Mintians. Would it be possible to lay out a detailed risk pathway on the role of the environment in the spread of AMR to humans and animals? So I guess we will have to understand how we evaluate the risk, no, and what are the transmission pathways.
Yeah, I think there is research out there on this, and but there's also still a lot of unknowns, and we will not answer them all within JAMRAI. So we will go on what we know. And try to collect as much evidence that is already out there, and also involve other experts that are working on it, sometimes not within JAMRAI, but we can invite them to think along. Yes.
And I'm very happy that they made this question, because actually in Spain, from the National Action Plan, in this we have this third part for the National Action Plan, for the section of the environment, and we are going to be focused on defining this framework for the evaluation of risk. So this is our next step.
Yeah, maybe also to go back to the presentation of this morning of environmental surveillance, it was also said there that it's not the answer to all risk questions, but at least we're collecting data that can feed into these assessments that will hopefully help to answer some of the questions.
Congratulations, ladies, because I remember when we were preparing, and you were saying that environment is new. And it definitely shows you had a very interactive session, and you got a lot of feedback from everybody and a lot of interest. So well done on your presentation. And how are you feeling? A little bit, do you want some rock and roll? Or are you ready to go on to the panel? Let's see, would anybody want to just stand up for a moment? I think just where you are. Okay, just where you are. Let's just get a little bit of movement, because the after lunch energy, it's sagging a little bit, you know, kind of just shake it out a little bit. We won't have music right now, but get a little bit of the blood moving, the oxygen going. Okay, there we go. Stretch it out, feel good, and yeah, have a 2-minute natter to your neighbor. Get that feeling going. All right. Oh, that feels good, doesn't it? No. Oh, this is just what you needed. Look at you. All smiles. This was well needed, huh? They needed this. Okay. All right. Okay, now the energy is flowing, the brain is going, we're all feeling good, and I'm going to invite onto the stage our panelists for this afternoon's little discussion. Absolutely, there we go. So, all right, so our different panelists, we've got from the World Health Organization, we've got Paula Coutinho. Okay, Coutinho. I've got to get these O's and A's right. I've been told it's really, really important because one is masculine and one is feminine. All right, then we've got the WOAH and we've got Mateus. Okay. Then we've got the FAO and it's Francesca Latronico. Got it right. And then we've got the EFA, Carolyn Whalley. Second time today, huh? Third time. Let's see, okay. And then we've got the ESGAP, Lucy Cato, online. Lovely to have you online and to join us with such a big smile. All right, we're really looking forward to this conversation, and we have now a conversation about the interlinked impact on our One Health activities, AMS and IPC, from a joint perspective. Now, once again, similar to this morning's session, I've been asked to conduct a conversational panel where I have two questions that I'm going to be addressing. Each of you, I'm going to give you an opportunity to do a short answer, and then if you have an answer or a rebuttal on that answer, just indicate and I will give you the opportunity to speak. The question that we really want to know about is how do you integrate a One Health approach across human, animal, and environment? Yes.
You're looking at me, is that because... Okay, I'll start the ball rolling. WOAH as part of the quadripartite, so we meet every 2 weeks as part of the Joint Secretariat for the quadripartite to discuss issues of antimicrobial resistance and how we can handle them from a One Health perspective. So therefore, during those meetings, we can actually share the issues of our different sectors because we all have different challenges, but we have common ground to work on. And therefore, we can see where we can work on the common ground. So that way we can bring on what we're doing in terms of animal health that can have an impact on human health, but also the agricultural sector, and also the environmental sector, because since 2022 we also have UNEP. And that's really important because sometimes we tend to focus a lot on the impact of all we do on human health, and we forget to bring on the other sectors. So it's very important that we have everybody represented in the discussions.
Okay.
Thank you.
Yeah, maybe also to complement. Okay. Well, indeed, so we meet like every week with Anna and also with other colleagues from like the WHO and also with UNEP, as she was saying. And I think that this has been beneficial. So you see, I think that if you have been like aware like of the progress, this has been, it has been a progressive improvement. Like because seeing a person like every week gives the possibility to really interact, to openly speak about what are the problems. I think that we have got a very good push, like also for this UN General Assembly, which had brought together all of us to discuss from the technical side, but also to interact with the member state and also with the different stakeholders. So also like to enlarge a bit more, so like I'm working for the Food and Agriculture Organization of the United Nations. So we are a UN technical specialized agency for food and agriculture. So we do take care actually from the food to fork, or if you would like to be more inclusive, from food to table, because not all people use fork around the world. But in any case, so I think that what also we support as a quadripartite is having discussion more open. So like we do have this multi-stakeholder and partnership platform, which is open for everyone that wants to join. And it brings really people from all different sectors. So we do have government, we do have private people, we do have university, research, we do have civil society. So this is also the possibility to bring people from different sectors, but also from different background and also interests. So I think that, yeah, this is my ad.
Okay.
Hello. Okay. So the short answer, and come back later.
Yes.
So as you can see by the large number of environmental representatives, we're quite new on the block here. So actually the engagement is actually to come to this sort of meeting where we can with the very limited resources and start learning and learning how to speak to each other and working with each other. And I think that's, you know, this is where we are with the environment. I mean, we had a very nice presentation earlier on about what JAMRAI is going to do and, you know, where we are at, really. Yeah, we're right at the start, really. So integrating One Health in the manner that's understood here, I think, is quite early days. But I can talk more about where we actually think we are doing some in the second term.
Okay, all right. Just by the way, don't forget, if you have questions, because we might have a little bit more time available, don't forget, you can ask questions on the Menti for the panel. I might be able to include them, all right, depending on time. All right, and our online panelist.
Fulfilling of this exercise is that we truly walk the talk of the One Health approach, right? That we have different areas of work or different approaches to how we are tackling antimicrobial resistance to make sure that we have the best of our efforts really synchronized. But you may be thinking, oh, she's so abstract, and then, you know, being far away, you know, on the screen, this sounds a lot of, you know, very blah, blah, blah. But to be very, very specific, just like last year, promote, you know, the integration of infection prevention and control and antimicrobial stewardship. And to do that, how we do? We're not going to reinvent any tool. We are not going to create a new assessment. That's great. We are going to use that already exists and make sure that the activity is truly tailored to the needs of the teams on site. And for that, we need to make sure that we receive input from all these AMR working group. And this, I think, it's a very dynamic exercise that we conduct every day for every activity. And for every time we are working on antimicrobial resistance. Sometimes the big flag is environment. Sometimes the big flag would be antimicrobial stewardship. And sometimes even the area of infection prevention and control, which is the area I am responsible for. But we have this saying in this working group, which I think it's pretty much, I hear this and I know it's true, that when you work with one of us from the AMR working group, you work with all of us. And this is pretty much the spirit of One Health approach, right? It's this true collaboration. It's not easy. We know that sometimes we need to accommodate different terminologies, different results from assessments that are not perhaps measuring something that we all, from our common starting point. But what is definitely true is that we have a common goal. And then I stopped here because I know I only had 2 minutes.
And that was the short answer? Okay. Well done. All right. That was a very, very lovely answer and full. Here you want to comment, yes.
So I would like to say that we don't only work on One Health as part of the quadripartite. So what we need to think is what we do as an organization or as a sector, how we impact the other sectors as well. So for instance, WOAH has this list for antimicrobials of veterinary importance, where we have recommendations for the use of highest priority critically important antimicrobials, which are really important for human health. So that's fluoroquinolones, colistin, certain fourth generation cephalosporins, and others. This means that we are giving instructions to those working in the animal health sector, so the veterinary services, to make sure that we preserve the efficacy of these antimicrobials, which is important for antimicrobial stewardship. For instance, don't use these antimicrobials as growth promoters, because the reality is we work at a global level. We have 183 countries that are members, and therefore it's not like Europe, and we still have countries that use growth promoters. That's an example. The other thing is, for instance, we also have a list of priority diseases for which we are asking the countries to invest in research and development or implementing vaccination programs for diseases where there's high use of antimicrobials, which can be important for human health. Well, if you prevent animal diseases, you reduce the disease burden in animal populations, and you also reduce, therefore, the need for antimicrobials, but also not only antimicrobials, for instance, acaricides in the environment, and also the emission of resistance into the environment, into also humans and to other animals and wildlife. So that's the thing. So it's considering then, for instance, vaccination programs have a wide impact, and they cost much less than doing the treatment. And that's what we often forget. And I think that's where considering this is like a side effect that you have, a ripple effect that you have in the other sectors. And then we need to think then, who is going to fund all of this? Who is going to pay for this? Is it only responsibility of the animal health sector? The governments need to think about these kind of things, and this sometimes is missing. So that's the issues that we're dealing with.
And I'm sure that tomorrow we're going to hear a little bit about that as well. Okay, I saw, yes, Caroline, you seem to have something that you want to...
Yeah, thanks. So when we were talking about preparing this session, and I said, well, what is IPC? And I was told it was infection prevention and control. And I said, okay, so what's that got to do with me? All right. And then we had a conversation about this, and it was okay. Oh, so now what we're talking about, and this is where we're linking onto what you're saying there, is that actually in the environment, a lot of the measures that are taken to protect the environment have that knock-on effect or unintended positive side effect, which is that they're also reducing the amount of AMR or other pathogens getting to the environment. So if you think about the original Urban Wastewater Treatment Directive, which is 1991, the objective of that EU legislation was to prevent harm to the environment through adverse effects of sewage discharges, essentially wastewater. And what that meant was that basically in most places, at least biological treatment, secondary treatment of wastewater sewage has been undertaken as required in Europe. But that also helps reduce the pollution load and the pathogen load and the AMR load just by putting that treatment in place. Now, what we can see, then similarly, things under the Water Framework Directive to prevent nutrients and organic matter getting into surface waters and groundwater, that also, the similar thing, if you're preventing animals trampling in the water, you're preventing that route going into, so it prevents pollution, but it's also preventing AMR and pathogens getting in that way. So these treatment methods, which are there to protect the environment, have this knock-on effect. Coming up to speed now with the revised Urban Wastewater Treatment Directive, and that's just come into force in January. And one of the things that's very important there is it's going to deal with some of the residual treatment that residual areas where there wasn't treatment. So, for example, ineffective septic tanks, or sort of that treatment where you haven't got wastewater treatment plants, where you've got runoff or stormwater overflows. So if you've got intense rainfall and it goes into to prevent the sewers flooding, the water's just discharged. So along with untreated sewage, just goes straight out into the environment. Okay, so that anything untreated, so that's all your pathogens, that's your AMR, whatever you like, that's in there, and that's what the revised directive aims to address. But something that's really important to understand is that it's also going to require quaternary treatment, so treatment for micropollutants and upgrading of a lot of wastewater treatment plants. Now, the thing about that is it's really expensive. It's billions and billions of euros, all right? And it's going to be it takes decades to do this sort of work. And once that wastewater infrastructure is in place, it's going to be there for 40 or 50 years. So if the wastewater treatment plants are a source of AMR genes to the environment, we need to know that really quick so that plant designers can get that into their treatment plants, and that the upgrades take that into account when they're being done. So for me, it's really important to very quickly know if wastewater treatment plant, that's a source to the environment that we need to deal with. All right, because that's got the implications that we can deal with that in the system that we've got set up, but it's happening now, it's happening fast.
Thank you, Francesca.
Yeah, just also to add, like, so as FAO, like EU is a member, and also all the different other EU member countries. So, and in fact, I mean, they shape like the resolution or like the different document that they are put forward from the organization. We have, well, you might know that we had like a different action plan. So now we are at the second action plan, but at the same time, so last year we have launched, we are trying to shift, like, let's say, the way in which we tackle the pollution. So we have launched an initiative, which is a 10-year initiative, and it is reduce the need for antimicrobials on farms. And also these farms are not only the farms that produce like the animal farms, but also the plant. So I think that this is something that has been, I've heard some speakers talking about plant, but not always. So I think that we also usually integrate plant only in the environment, while, well, it might have some specificity that does not need to be put as part of the wider environment. So one point, like, so it is like we have now introduced like this reduce the need for antimicrobials, and of course this is strictly linked to the antimicrobial stewardship and IPC, or like how we call it the biosecurity in the farms. So that needs to be followed, and it is really to support in every corner of the world, like all the different farmers that have to implement. So enabling them from different ways, which are from the regulatory aspect, which is also core of our like mandate, but also like with capacity building. And just also because it has been a lot of talking regarding behavioral science, so we have been already implementing from some years what we call the farm field school, and I think that the different experts also in the room have contributed in developing the training, but we have included social and behavioral science, like so developing manual to integrate also the component of the antimicrobial stewardship and IPC, really like with the aim to reduce antimicrobials to be used, but also to avoid that they are spilled over like in the environment, in the farm environment where they are used. So yes, so just yeah, to add that, I mean, we are actually working like on also including the plant sector like more strongly. So please also consider this in your work more specifically.
Lovely. Anna, do you want to add something online, Anna?
Well, I think my colleagues gave a great idea, great perspective of how much we are really trying to coordinate this work amongst different technical agencies. And we know when it comes to the country level, sometimes this also, we are, working perhaps with different ministries or stakeholders. But what matters at the end of the day that, and I know that this is also practiced in the other UN agencies and other agencies that are, represented today in this meeting, is that, this value of when you work with one person in that organization, you really have the benefit of working with all of them. And sometimes even that our assessments and sometimes the terminology is a bit different, which is normal, right? We're talking about different areas of work. But I don't know in the audience how many of you are, familiar with the results of these tracking antimicrobial resistance systems that we have there is a platform that's called TRACS. And I've been following this platform since 2017. And then I saw when, there was a newcomer, right? It was initially tripartite, then quadripartite. And now, you see it's wonderful to see all these responses. And this is all in the public domain. So we also need to, make sure that, we have this moment that we as different technical agencies, we come together to gather all this information. This information has to be used by us and also by you.
I think that's really important, that the information, the terminology might be different, the methodologies might be different, but the outcome and the desired outcome remains the same. And so when you stay focused on the outcome, there are definite synergies in what you're doing. I'm going to move on to the second question at this particular point, and that is, do you have specific advice for EU-JAMRAI in the improving or the impact of interlinking animal, the human and environment? Okay, that was your second question. Do you have advice? I mean, you've added already some lovely little gems.
I think, well, I'm going to go a bit, as you know, many countries are working on implementation, the development and implementation of national plans on AMR, and that's where all should have multi-sectoral teams working together, representing the 4 sectors, so animals, humans, plants, and environment, and we should all bring together. But the thing is, there's issues in terms of resources for the different sectors. So when you look at the national action plans, you usually have very well represented the human sector, but then you don't have so much the other sectors. Maybe you have human and animal, but then the others, you don't see them. And we need to bring all the stakeholders together, but also bring resources to fund the activities across the sectors to ensure that we really have, not only on the paper, a One Health approach. And I think that's one of the issues that you said. Probably tomorrow there will be discussions on resource mobilization, and also considering that although it might not be your sector, but if it has an impact on your sector, and it's been, you identify a hotspot or a bottleneck in a sector that you're trying to address, should all the sectors be contributing because the impact is seen across? And I don't know, here, obviously in Europe, is very well organized. In low middle income countries, that's more difficult, but Europe is not separated from the other countries. We have international trade, so you have movement of people and live animals and food, and therefore some countries already are seeing that introduction of AMR coming from other sources. So think about that when you're doing an intervention in a sector, there's targeted intervention that you might have actually an impact on stopping the transmission, a pathway for transmission of AMR. And
a spin-off.
Yeah, a spillover. Yeah, a spin-off. So that's really important. But we need the resources. And that's where sometimes that becomes...
Well, I think at the moment EU-JAMRAI are well placed with all the generosity of the different organizations in bringing this together. How it gets used, obviously that needs to be defined, but certainly EU-JAMRAI is the right place to have these discussions.
Yes, so for me, 3 points. So first of all, I think that it is One Health. So I think that this is like, I don't think that still people understand what One Health is. So we often have this challenge. So I'm a veterinarian as a background, and usually I think that I have to, so we do have this wonderful definition that it is interlinked, interconnected, but then when it comes for me to explain to a medical doctor that it is like also the animal health and not the animal, so the animal are useful, so they also have a right to the health. So it is not that they are only need to be seen as sources for food. So it's really like to shift. So it should be really be us having like not an anthropocentric One Health definition, but it is truly a One Health like understanding. Second point, it is that whenever, like I think that Europe is a place, I mean, it has a lot of resources, and of course, this is a privilege. But so whenever, like, you think on a solution or like developing something, will be useful if it is done if you think that could be done in a progressive way. So also in other part of the world, when this situation is a bit, there is less resources, but it may come in the future. If it is good to give a pathway, so like to give like a progressive way to reach, so to reach the final goal, but maybe people have to start from a lower situation, lower step. And then as a third point, please, be as a UN organization, we really listen to everyone, so you are also part of it. And then will be very useful to have always you in the global discussion. So as I was saying that in this multi-stakeholder partnership platform, but also we have developed a document together with also experts from Europe, and those are useful for research, and I'm specifically referring to the MR One Health Priority Research Agenda, in which there are pillars that they also speak directly to the surveillance, like the integrated surveillance, the transmission, the behavioral insight and change, and then we do have also intervention and economic and policy. And those have been identified 62 research areas that maybe can guide also your research, or your research can also provide a reply to a specific research question. And we are actually also working together with the Global AMR Research Development Hub also to track fund and resources that goes, and research project that goes in filling this gap. So I think that, please be also aware about what it is out there outside Europe that you can contribute, and we can also get benefit from you. Thanks.
Thank you. Lizzie.
Caroline.
Caroline.
It's okay.
It's getting to the end of the day, so sorry.
It's okay. So I think in most cases, the resources available to environmental projects, and we park urban wastewater slightly differently, orders lower than to medical or in sort of human or animal health kind of areas. The resources, if you get €1 million to do something in the environment, right, that's a really big project. Okay, and so actually when I was thinking about this question, it's, if JAMRAI could give us some of the economic value, the benefits, of this prevention activity that actually we could use in an environmental context, so that helps us to protect the environment. Actually, that sort of information, if you know what I mean, so sort of whether it's dailies or qualies, that says, actually by using this measure, you can prevent this much harm, and giving us some quantitative data in terms of value of that could be really useful, because actually, it can be very difficult if you just saying, oh, well, the birds will come back, or we'll get some more fish, and people, yeah, that's nice. Actually, if you're improving the biodiversity, that's got a value. And if you're improving the quality of life and you're reducing infection and that sort of thing, actually getting hard numbers there really can help improve the environmental case for doing work.
Thank you very much. And the last word for our panel today is Anna from online. Okay, if you can give a final word, we're about to close now.
Okay, so where were we 5 years ago? We were at the beginning of the COVID-19 pandemic. And there were so many lessons identified, and we can't just ignore those. So my advice to the wonderful EU-JAMRAI family is, number one, continue exercising inclusion. I know you do. Continue. I know it's difficult, and I applaud you for having the courage and never stopping to try. The second thing is really, please try to strengthen collaboration between the different work packages. Your example will set the tone, will put the bar at the right height that we need. And the last, but not least important, is just to say that we can't never lose sight of our intended audience. Human health, animal health, environment, right? We always have to look always back, because this is what keeps us, moving ahead in direction, because everything we do is to have an impact in that context. So congratulations all the EU-JAMRAI leaders. I think it's magical what you do. I had the opportunity to participate in the first EU-JAMRAI, and seeing now, the amazing progress. It's wonderful. It's a privilege. Congratulations.
Whoa. Okay. All right, guys, let's get energy, because you're not only giving the panel a hand, but you're giving yourselves a hand. Let's get that energy going. Come on. Let's go. Let's go. Let's get movement. Yes. All right. All right, congratulations, ladies. Thank you for a lovely discussion, and I invite you now to leave the stage, and I am going to invite Brian. Brian would like to conclude, to wrap up the session for today. Thank you, Brian.
Yes, hello, Brian Christensen from Denmark, SSI, and on behalf of the wonderful people working with the AMS and IPC, I would say thank you for your panel with very good input, and I hope you understand that we are trying really hard to work to enforce implementation of AMS and IPC by doing sharing knowledge, trying to update and create frameworks within AMS and IPC, and doing a lot of peer-to-peer programs within AMS and IPC. We had our first webinar, our first JAMRAI webinar on IPC 3 days ago, and to us it was a success. We have 400 persons being part of it, and it is more to come. And at last, I want to emphasize, most of us here are from governmental bodies and institutions, but do not forget that when we are talking about implementation, it is all what is going to happen at the hospital, at the vet clinics, at the long-term care facilities. It is actually your work translating what we are talking about today, what we do understand today, how to translate into practical dialogue and information and action. I hope we will do well. I think we are doing it. Thank you.
Thank you very much, Brian.